Hello everyone, we are now going to go over peripheral blood flow cytometry from a 16-year-old boy with leukocytosis and numerous circulating blasts. So let's start with CD45 versus site scatter. And we have a small number of cells in this gate, which is the lymphocyte gate, which is 3% as shown here. And these have bright CD45 and low site scatter. And there is essentially nothing in the monocyte gate. The monocyte gate has bright CD45 and slightly higher site scatter than the lymphocyte gate. And we have 19% cells in the granulocyte gate, which has very high site scatter and a dimmer CD45 than lymphocytes and monocytes. We have a lot of cells in the blast gate, which is identified by a dim CD45 and low site scatter. And now let's follow through the blast and see what they express. So the blasts are negative for CD34 and CD33. They're negative for HLA-DR and 117. They're negative for CD13. They're negative for, they're positive for CD38. They're negative for CD64 and CD14. So they're negative for the myeloid markers, 117, 33, 13. And they're also negative for CD34 and HLA-DR, which are kind of the immaturity markers. They're negative for monocytic markers, CD14 and CD64. And they express bright CD7. They are largely negative for surface CD3. There's a small number of cells here, just 2% of the blast that express surface CD3 and CD7. They are double negative for CD4 and CD8. They express partial dim CD2. And again, here we see a small population that is positive for CD2 and surface CD3. They are negative for CD19 and CD10. They are negative for CD20. So they're negative for B cell markers, the 19, 10, and 20. So far, we only see CD7, partial CD2, and CD38. Although CD7 and CD2 are T cell markers, they are not lineage specific. The only lineage specific marker for T cells are the CD3. So surface CD3 is largely negative. We see a small population that is CD3 positive, but that's not enough. We need to evaluate to see if there is expression of cytoplasmic CD3. So we have to remember that surface CD3, if surface CD3 is negative, that does not eliminate the lymphoblast totally. We have to look for cytoplasmic CD3 expression. So now we added on our cytoplasmic tube, which has, along with cytoplasmic CD3, TDT, CD5, CD1A, and also cytoplasmic MPO. So in this tube, we can see that the blasts, which are in painted royal blue, they are all positive for cytoplasmic CD3. They are partially positive for TDT. So now we know the lineage of the blast, which is T cell lineage, and also they have the immaturity marker TDT. And they have CD5 expression. They do not have CD1A expression, and they're negative for MPO. So we have 75% blasts, so we can comfortably call this as T lymphoblastic leukemia lymphoma. So the important things that we can see here is that they have cytoplasmic CD3, but they're negative for surface CD3. So if you remember in T cell maturation, originally the CD3 is expressed in the cytoplasm, and later when the T cell receptor genes rearrange and a TCR complex is formed, the CD3 will bind with that and then migrate to the surface. So that's when surface CD3 expression is seen. So surface CD3 expression comes much later, like for in the late stages of cortical thymocytes, but in the early precursor stages, they are usually negative. CD7, if you remember, is consistently expressed from the bone marrow stage to the mature lymphocytes in the peripheral tissues. So CD7 is always positive. They are usually bright, they can be sometimes dim, but they're almost always positive. And if you also remember, followed by CD7, CD2 and 5 are the earliest T cell markers that are acquired. So we see that here, CD5 and CD2 are positive, and cytoplasmic CD3 is positive, and TDT is positive. If you remember the earliest precursors that are in the marrow, they are positive for CD34, and the subcapsular thymocytes are also positive for CD10. Maybe these are a little in the next stage. That's why the 34 is negative and 10 is negative. And also 4 and 8 are are both negative in these cells. So in cortical thymocytes, we have two stages, both double negative and double positive. And usually the double negative stages do not have surface CD3, and the double positive stages have surface CD3. So all of these matches. Although the blasts do not have to follow the normal maturation pattern because these are neoplastic, they can have some asynchronous expression. But anyways, we have the cytoplasmic CD3 and immaturity markers, so we can comfortably call this as T lymphoblastic leukemia. Lymphoma. So in our reporting, the top line, we would say T lymphoblastic leukemia with 75% blasts, and we would elaborate the phenotype of it. It is important to document what markers are positive and to what extent, that is the intensity. If it is partial or bright, we have to document that because we need all that data when we follow up these patients for minimal residual disease in future, because that's going to be a minor population, and we have to make sure we distinguish them, we identify them distinctly, and the prior phenotype always helps. Thank you.